Tell me something. Picture a crowded marketplace in Lagos. First week of the COVID 19 lockdown. Half the vendors are wearing masks, half are not. Same information, same disease, same markets. Completely different decisions. I watched this happen, and I've spent years as a physician, as a public health scholar, trying to understand why. The answer is not ignorance. Those vendors had phones, they had the information. The answer is something more fundamental, something that lives in the architecture of the human brain itself. Before we begin, an important note. This episode is for educational purposes only. It's not a substitute for professional, medical, psychological, or public health advice, diagnosis, or treatment. The content draws from an introduction to global community health psychology, written by Dr. Anthony Iyore and Anaweokhai, and published by Routledge in 2026, and from peer-reviewed academic sources. Health science evolves. Always consult current guidelines and qualified professionals. If you are experiencing a health concern, physical or mental, please seek qualified professional support. Links to resources are in the description. Welcome to Global Community Health Psychology, the full course. I'm Dr. Anthony Iyore Anaweokhai, MBBS, MBA, MSc, MPH, PhD, Director of the Anaweokhai Institute for Applied Global Health, Port Harcourt, Nigeria, Routledge author, Public Health Physician. Series 1, Foundations, Episode 1. Today we open with Chapter 4 of An Introduction to Global Community Health Psychology, published by Routledge in 2026. Risk perception and health decision making, in other words, why people ignore health warnings, the neuroscience. In this episode, dual process thinking, System 1 versus System 2, the three cognitive biases that consistently destroys public health messaging, cultural frameworks for risk across individualist and collectivist societies, the WHO forces model of vaccine hesitancy, and the one variable that overrides everything else. If you do not understand how the human brain actually evaluates risk, nothing else in public health makes sense. That Lagos marketplace is not unique. Every country, every culture, every outbreak in history has produced the same splits, the same community, the same information, two completely opposite responses. And for decades, public health tried to solve this by improving the information. Better leaflets, clearer statistics, louder announcements. It did not work. Not reliably, not at scale. The robust finding, replicated across populations, across income levels, across literacy levels, and across cultural contexts, is that providing accurate health information does not reliably change health behavior. The gap between knowing and doing is not a gap of ignorance, it's a gap of architecture. And the architecture of the human brain. 3 wrong answers first, then the right one. Your brain has 2 operating systems, and only one of them reads your health leaflets. Daniel Kahneman, the Nobel Prize winning psychologist, described 2 systems of thinking that operate in every human brain. System 1, fast, automatic, intuitive. It runs constantly below the level of conscious thought, processing thousands of signals per second and generating instant responses. When you smell smoke and feel afraid before you consciously register fire, that is System 1. System 2 is slow, is deliberate, is analytical. It's the part of your brain that reads the health leaflet, considers the statistics, and weighs the evidence. It's capable of sophisticated reasoning. It's also exhausting, which is why it activates only when necessary. Public health has been designed for System 2. Communities experience it through System 1. And when a crisis begins, when uncertainty is high, when time is short, when emotional signals are firing, System 1 takes over completely. Here's the part they did not teach you in medical school. The amygdala, the brain threat detection center, processes emotional risk signals before the prefrontal cortex has had any chance to apply rational analysis. The emotional response arrives first, the logical response catches up later, if at all. This is not a failure of intelligence, this is the brain working exactly as it was designed to work. The problem is that public health interventions have been designed for a rational actor who reads information carefully and changes behavior accordingly. The communities that do not respond to those interventions are not irrational, they are human. Now, the three biases that compound this, operating in every brain on earth, regardless of education, of income, or of culture. Three biases. Every population, every country, every community you ever work in. Bias 1, the availability heuristic. People judge the probability of an event based on how easily an example comes to mind. If you've personally known someone who died from COVID-19, your perceived risk of COVID-19 is high. If you have not, your perceived risk is lower, regardless of what the statistics say. In communities where infectious disease outbreaks have been frequent, people reliably overestimate epidemic risk. In communities, however, where chronic disease have dominated experience, they reliably underestimate it. Neither group is being irrational. Both are using lived experience as their primary data source. The implication, if you want to change risk perception, make the risk experientially available through testimony, through story, through visible consequence, not just statistically available through numbers. Bias 2, optimism bias. People consistently underestimate their personal risk compared to others. Ask anyone if they are more or less likely than average to develop cancer, to have a road traffic accident, or contract a communicable disease. The majority will say less likely, even when the mathematical probability is that half of them must be wrong. Research shows optimism bias is more pronounced in individualistic cultural settings, where personal invulnerability is psychologically reinforcing. In collectivistic settings, the bias shifts. People may accurately assess community risk while still discounting personal vulnerability. Health messages that say you are at risk often fail because they clash with a neurologically reinforced optimism bias. Messages that say the people around you are at risk and you have the power to protect them work better because they do not trigger defensive discounting. Bias 3, confirmation bias. People seek, interpret, and remember information in ways that confirm what they already believe. In the age of social media, this is no longer operating on a slow trickle of information. It is operating on algorithmic feeds specifically designed to show people more of what they already agree with. The result, accurate health information presented through official channels reach populations that already accept it. Populations that do not accept it are inside information ecosystems actively reinforcing their alternative frameworks. You cannot correct confirmation bias with more information alone. You need trusted messengers who exist inside the alternative ecosystems who can present evidence within a framework the community already accepts. Which brings us to the most important concept in this chapter, culture. Here is one of the most persistent errors in global public health, treating cultural variation in health beliefs as a problem to overcome rather than a system to work with. Different cultures maintain fundamentally different frameworks for understanding health risk. The biomedical model, which dominates Western health communication, emphasizes biological causation, individual susceptibility, and statistical probability. It is one framework. It's not the universal framework. In many African cultural contexts, health risk is understood relationally. Disease may be conceptualized as social rupture, a breakdown in community relationships, in family obligations, in spiritual alignment. The appropriate response is therefore social and relational, not purely biological. In many East Asian contexts, health is understood through frameworks of balance and harmony between opposing forces, opposing bodies, and opposing environments, individual and collective. In many indigenous communities worldwide, risk conceptualization is ecological. The health of the individual is inseparable from the health of the land, from the health of the community, and from the health of the ancestral network. None of these frameworks are wrong. Several of them anticipated insights that Western epidemiology arrived at much later. The social determinants of health, the importance of community cohesion, the relationship between environmental degradation and population health. If your health communication does not speak the risk language of the community you are trying to reach, it will not be received as health communication. It will be received as foreign noise. The WHO captures this with a 4-part model that changed how vaccine communication is designed worldwide. So why do communities hesitate before vaccines? The WHO has a framework, 4 C's. Confidence, trust in the vaccine and the system delivering it. C number 2, complacency, low perceived risk of the disease itself. C number 3, convenience, practical barriers to access. And C number 4, communication, whether the message reaches people through channels they trust, in language that fits their framework. This model's power is in its diagnostic function. It moves beyond why wouldn't they listen to facts towards what's actually driving the decision in this specific community. The answer is almost always a combination of all 4 C's weighted differently by cultural context, which means no single communication strategy works across all communities. The intervention must be designed for the specific weight of each C in the specific population being reached. But underneath all 4 C's, underneath every framework we have covered in this episode, is one variable that overrides everything else. If I had to identify the single most important variable in health risk communication, it will not be the quality of the evidence, it will not be the clarity of the message, it will not be the literacy level of the audience. It would be trust. Communities that trust the institutions delivering health information accept that information at rates broadly consistent with the evidence. Communities that do not trust those institutions apply a discount, sometimes a total discount, to everything those institutions say. And that distrust is not irrational, it's often historically justified. Communities that experience the Tuskegee syphilis study, colonial medical experimentation, health systems that consistently failed them, governments that consistently lied to them. Those communities are not being irrational when they apply skepticism to official health guidance. They are being historically informed. You see, trust is not argued into existence. Trust is built through consistent action over time, through accountability, through demonstrated care, through trusted intermediaries who translate institutional messages into community-endorsed ones. It takes years to build. It takes one scandal to destroy. Which means the most important investment in pandemic preparedness is not stockpiling ventilators, it is building and maintaining trust with communities before the emergency begins. 5 implications, then we close. 5 implications from this chapter for everyone working in health. 1. Design for System 1, not System 2. Make your message emotionally resonant before you make it factually complete. Narrative and social proof activate System 1. Statistics activate System 2, which requires conscious effort that most people, under most circumstances, will not deploy. 2. Address the availability heuristic directly. Make the risk visible, not just statistical. Stories of specific individuals shift risk perception more effectively than population-level numbers. 3. Use collective framing for collectivist audiences. Protect your community. Activate stronger motivational response than protect yourself. 4. Work with cultural risk frameworks, not against them. Identify what the community already believes about the source of ill health and work within that framework. Integration outperforms replacement. 5. Identify the trusted messengers. They are rarely government health officials, they are community leaders, religious figures, traditional healers, respected elders, people whose relationship with the community predates and outlasts any institutional intervention. This episode is based on Chapter 4 of An Introduction to Global Community Health Psychology, published by Routledge in 2026 and written by Dr. Anthony Iyore and Anaweokhai. The full text is available on Amazon and directly from Routledge on their websites. Links are in the description. If this episode has been useful to you, the book goes considerably deeper on risk perception, vaccine communication, and the neuroscience of health decision making. ISBN 978-104-120-4152. Episode 2 covers Chapter 8, Health Inequities. The question we ask there are: why does your postcode predict your health more reliably than genetics? If this episode has been useful to you, here is how to go deeper. Subscribe to this channel at Anaweokhai Institute for the complete books to video library from the Anaweokhai Institute for Applied Global Health. New episodes every fortnight. The Health Dispatch, our weekly newsletter, goes deeper on every topic this series covers. Free and paid tiers, link in the description. The Practitioner's Course in Global Community Health Psychology is available on Gumroad. 8 weeks, everything this textbook covers, built for practice, links in the description. And the textbook itself, An Introduction to Global Community Health Psychology, is available from Routledge and on Amazon. Everything begins there. Health is not destiny. It's been Dr. Anthony Iyore and Anaweokhai. I'll see you on the next one.